Hello, my name is Spencer Liebel. I'm an assistant professor and clinical neuropsychologist in the Department of Neurology at the University of Utah. Today, I will be providing a brief overview and lecture of the neuropsychological evaluation of adults with acquired brain injury. So, we will discuss what is an acquired brain injury or ABI, and then the role, purpose, and the medical value of neuropsychological evaluation in the treatment and outcomes monitoring of an individual with acquired brain injury. So, we'll talk about the components of a neuropsychological evaluation in these groups, how those processes work, the influences that affect neuropsychological evaluation, and then some of the challenges related to neuropsych evals in acquired brain injury patients. And then finally, we'll briefly discuss what is the current state and where is the research going in ABI as it relates to neuropsychological evaluation involvement. So what is acquired brain injury? Put simply, an acquired brain injury is an injury to the brain that has occurred after birth. So it's an injury that is not hereditary, congenital, degenerative, like Alzheimer's disease or another dementia, or induced by the actual birth trauma. So these are brain injuries that have occurred after birth. There are many types of acquired brain injury. Acquired brain injury is an umbrella term that encompasses a whole host of different types of injuries. The most common cause of acquired brain injury are traumatic brain injury, like that might happen in sports or in a car accident or a fall, and stroke, whether those are different types of strokes that occur in the brain. These are the two most common categories. However, as I said before, many types of injuries unfortunately fall under the umbrella of an acquired brain injury, things like a brain tumor or a disease or infection of their central nervous system, exposure to toxins, lead, mercury, etc. Anoxia or cutting off of oxygen to the brain can cause an ABI. Alcohol and drug abuse may cause an acquired brain injury. And there are more that are not listed here. As we move forward through this brief presentation, the primary causes of ABI are assumed to be traumatic brain injury and stroke, but just know there are many types of injuries to the brain that would fall under this umbrella term. Now, speaking broadly, there are three primary consequences of acquired brain injury, and the mileage varies on each of these dependent upon the mechanism of injury. So as I've said, ABI is an umbrella term, but briefly and kind of a broad strokes, the three primary consequences of ABI can be categorized as cognitive, psychological or psychiatric, and physical and semantic, or somatic rather. Some of the cognitive consequences, and those are especially important to a neuropsychologist, are manifested by declines in things like attention, working memory, learning and memory, executive function. However, these are just some of the common cognitive consequences. There are others, and these sometimes are dependent upon the location in which the brain was injured. For example, an individual might experience visual spatial or perceptual reasoning declines dependent upon if the stroke per se occurred in parietal areas of the brain. The next common consequence of ABI are psychological or psychiatric. Many individuals who sustain an ABI experience anxiety and depression related symptoms. So for depression, again, an umbrella term, it might mean things like lethargy or wanting to withdraw from others. It might affect your irritability, or you might be more quick to anger, disrupted appetite, whether overeating, undereating, or impair or influence the way that an individual emotes. They might be flat, or they might be the opposite. They might be emotionally labile. And then sometimes research is suggesting that individuals who sustain an ABI, broadly defined, might have an increase in their aggression or irritability. And then in the third consequence, we have physical slash somatic complaints. These are things like hemiparesis and hemiplegia, or one body side is weak, or it might be paralyzed altogether, dependent upon where the ABI occurred in the brain. Individuals with an ABI often have balance difficulties, headache, their sleep becomes messed up, or they might be generally fatigued or lethargic. So really you can see that the consequences of ABI spread the gamut of many different body systems, whether those are mental, physical, or cognitive. So the neuropsychological evaluation in ABI is by definition typically comprehensive to account for all of those things that I just talked about. Meaning we want to know what is an individual's functioning after an ABI in those three broad areas. And so the neuropsychological evaluation might be quite long, or at least attempt to touch on, at least briefly, each of those domains. But this isn't always the case. Sometimes there are circumstances in which a comprehensive neuropsych eval is not appropriate, or an option for an individual who has an ABI. Perhaps an individual experienced a traumatic brain injury due to sport, and there's only a brief time on the sideline to evaluate very briefly cognitive functioning and balance and things like this. Or the patient might be on inpatient in the hospital, and so there is limited time and resources to go to them and present to them these evaluations. So there are all sorts of circumstances and confounding factors that influence how a neuropsychological evaluation takes place. Though I will say on an outpatient basis, which is my area of expertise with these folks, I attempt to do a comprehensive eval virtually all the time. Now, the purpose of the neuropsychological evaluation in these folks is to identify cognitive strengths and weaknesses. And now these might be pre-existing, or these might be new due to the ABI, and that's my job to sort of figure out. And then I want to know about new onset of psychological and somatic symptoms, as we discussed. And I use these results of cognitive strengths and weaknesses and psychological functioning to formulate tailored and specific intervention strategies for the patient. So at the end of my neuropsychological evaluation reports, I list out recommendations or interventional strategies that I think will help based upon what was found in my evaluation. Sometimes these things are cognitive in nature, or psychological, or somatic, or all three. Things like I might recommend that the individual begin individual and group psychotherapy, and I'll list out resources how they might find a psychotherapist. The results of my evaluation might show that their sleep is significantly disrupted, such that they're not getting enough restful or restorative sleep. So I'll suggest ways to improve their sleep hygiene, or even make a referral to a sleep medicine physician. A lot of times people with ABI will have significant pain, whether that's musculoskeletal or otherwise, and so I'll refer them to a pain management specialist, or refer them to a psychotherapist who can treat pain via CBT for pain. And then sometimes I might make recommendations that are pretty broad, like this individual has various vascular risk factors, like high cholesterol and high blood pressure. And these things need to be monitored in order to prevent downstream injury or consequence to the brain. So really the findings of the evaluation dictate how I might hope to intervene for this patient, and it changes patient by patient. And we'll talk more about this heterogeneity here in a few minutes. So what are the components of a neuropsychological evaluation in this cohort, or in this patient group? First, as an outpatient provider, I receive referrals typically from neurologists, physical medicine rehabilitation physicians, or primary care physicians. And the first thing that I want to know is, how long has it been since the patient had or sustained their ABI? And the reason that this is important is because we don't want to do a neuropsychological evaluation on an outpatient basis when the patient is in an acute stage of recovery, say less than 3 to 6 months since, for example, a traumatic brain injury. After 6 months is when I would prefer to see them. Typically a year is how it goes. Again, if the person was just sent home from the hospital and they want to see me the next week, it might not be the best time, because they are still technically within that post-acute recovery stage, and my evaluation is going to be affected by that occurring recovery process. Finally, or next, after I accept the referral and they get onto my schedule, I perform, as I do with all neuropsych patients, a clinical interview. And this is simply sitting down with the patient, and we ask that they bring a collateral, or someone who knows them well. and we ask questions about the injury itself. So for example, with a traumatic brain injury or other types of ABI, I want to know about lock, which is loss of consciousness. How long were you frankly unconscious due to this event? What was your last memory? What was your first memory after the event? Did you experience any retrograde or anterograde amnesia? Were you hospitalized? Were you taken to the hospital by an ambulance? All of these things are data points that help me to determine how severe was this brain injury, and it also helps me understand that what might be their outcome and their outcome over time, because research tells us certain factors influence how people recover or don't recover after such an injury. I also ask a lot about their immediate and persistent symptoms after an ABI, meaning they immediately upon being, struck in the head by the car door or what have you. Were you nauseous? Were you dizzy? Did you vomit? Did you pass out? Whatever these are immediate symptoms. And then what were some of the symptoms that occurred maybe a day later or 2 or 3 days later, whatever it is? Again, these are all data points helping me to understand the severity and nature of the acquired brain injury. And then, of course, as a neuropsychologist, I'm particularly interested in what were the cognitive consequences of this accident or this injury? What were the domains of functioning that you experienced declines in or deficits in? How have these deficits affected your daily living? Can you still bathe and shower on your own and eat? Or is it affecting higher order or independent activities of daily, like managing finances and medications or driving, etc.? So when I'm setting up, once I've finished the clinical interview, I move into the formal cognitive evaluation stage of the assessment, wherein the patient is administered various standardized neuropsychological assessment measures of things like processing speed, working memory, executive functioning, language functions, visual spatial functions, learning and memory, motor functioning, and then performance and symptom validity testing. So as you can see here, we really try to touch on all of the major domains or players in cognitive functioning that might possibly be affected by an acquired brain injury. And then we administer psychological assessments to figure out on a quantitative basis what are some of the symptoms you're experiencing of anxiety and depression and changes to your personality and behavior. And these typically take the form of self-report questionnaires wherein the the patient is handed a form wherein they say, yes, I experienced this symptom, or no, I do not, or this has changed, or that, whatever. And we can track and quantify what that might mean for them. And then I take all of this data and I integrate it with the medical record, usually an electronic medical record, and I integrate it with the report of the collateral who is telling me, I'm seeing this at home, or I'm seeing this, or this has changed for the worse, or this improved, or what have you. All of this is to pull in data to get a comprehensive understanding, as much as I'm able, of how this acquired brain injury affected the patient according to these large areas. So as you can see, a lot goes into a neuropsych eval for such patients. And typically these evaluations, and this is totally dependent upon what type of practice you have, or if you're in a hospital system or private practice, or in an academic medical center, or in a university, whatever, all of this is unique. But typically across all of these domains, or all of these aspects of the evaluation, I'm with the patient for 3, maybe even 4 or 5 hours, depending. So then, once the patient has gone home for the day, I need to interpret all of these results, and I need to take into account their cognitive functioning, their performance on individual tests, and I need to understand the interplay of any psychological symptoms, what the collateral said, what did the neuroimaging that was done in the hospital say, etc. I'm trying to take all of these points in. And I think it's important to note that a neuropsychological evaluation does not frequently have strong heuristics for ABI, meaning there are not typical patterns or agreed upon presentations for a specific ABI, as there is for maybe an Alzheimer's disease, where we know that people with Alzheimer's disease are amnestic, meaning they struggle to learn and recall new information. And so what I'm looking for when I'm looking at the cognitive results of this testing, I'm looking for patterns. Perhaps an individual is struggling with more executive functioning like tasks like planning and inhibition or organization, and they're not struggling with language or speeded tasks or what have you. So I'm looking for rough patterns that kind of point me in the direction of what might be ailing them. And then I'm also trying to identify uh, performances on these cognitive evaluations that I would call one-offs, or maybe a circumscribed deficit or weakness that probably isn't a true weakness, but maybe they just did poorly on a certain test because of who knows what reason. And then I need to decide, are what individuals showing me on the neuropsychological evaluation results, are these weaknesses for them or are they true cognitive impairments? And there's a difference there. An individual who has an impairment in a specific domain, has struggles to really do the thing, like learn new information and recall it later. Whereas if you have a weakness in this, you can still do it, but maybe you're not as uh, good at it as you were before the injury, or you're less fast, or what have you. And so this differentiation between weakness and impairment is critical. And like I said, I take all of this into account and I put this silly graphic on here, which is not related to neuropsychology, but just to show that all of these data points intersect with one another. And I'm trying to form a comprehensive picture. And I'm trying to understand, do the cognitive results affect psychological functioning or vice versa? The answer is yes, always. And to what extent and to how severe? And I'm using these kind of abstract integrations as a way to collaborate with my healthcare teammates, meaning I can then communicate to the referring provider and other people on the patient's medical team about what I'm seeing and how this might look like a pure executive functioning weakness or impairment in this patient. However, I really think it's related to their significant depression and anxiety. And so we need to go that route in treatment. And I'm communicating all of this to these other providers so as to be a help to move forward the care of these patients. So what are some of the rehabilitation or intervention strategies that I might suggest an ABI patient undergo? One of the big ones is cognitive rehabilitation, sort of learning tools and skills and tricks to make up for any of the cognitive deficits or impairments that they might have. And this is done typically on an outpatient basis, can be done inpatient, but typically on an outpatient basis by a cognitive rehabilitation specialist. These are typically clinical psychologists who have advanced training in the dissemination and teaching of these tools and skills. And then a big part of my role following the neuropsych eval is providing education both to the patient and frequently to their families about what is going on with the patient's brain and cognitive and psychiatric functioning as a result. And I might talk to them about what are things that are influencing their recovery, things like their mood, or perhaps substance use, or their sleep, or their pain, whatever it is. And I detail to them how these things are intricately and intimately related. And then I might talk a little bit about how we might adapt to some of these changes that they've experienced. And we talk about neuroplasticity and reorganization, meaning the brain is not totally dissimilar to other organs or muscles or parts of the body in that it can change and heal, and that the brain is pretty good at making up for any sort of deficits if we give it time, though this might go down as we age. And so the idea is to suggest to the patient and their families that there are ways we can influence recovery and adaptation, and that we can start to influence how we recover, because this is not a one-stop recovery, rather it's a prolonged process typically. And again, group and individual psychotherapy are often a critical component of my interventional strategies, because it helps people come to terms with their injury and deal with the downstream mood related consequences. And it is of the utmost importance. Now, as I have alluded to throughout the presentation, there are several challenges to the neuropsychological evaluation of patients with ABI. And perhaps the greatest one is that these injuries are heterogeneous and they result in heterogeneous symptom constellations, meaning these injuries tend to be different and by person, and then each person tends to experience symptoms that are different from one another. Meaning, some folks might have a sport-related concussion and they experience depression and sleep problems, while another athlete might have a similar type of concussion and they don't experience depression or sleep problems, but they experience fatigue and they have headache. And so you can see that it's the same injury, but not really. And now the symptom constellation is also different. And so as a neuropsychologist, I'm constantly pulled and pressed and challenged to account for this heterogeneous nature of the injuries and the symptoms that come as a result. And so that what this says here is one size does not fit all in the evaluation of these patients. And one must be a flexible neuropsychologist to take into account all of these differentiations. Then there are also cultural and linguistic considerations, and this is not only true for neuropsych evals in ABI, but for neuropsychology broadly. We have to appreciate cultural differences and language and linguistic differences based upon what we know how these things affect cognitive functioning and the testing of cognitive functioning. Of course, we need to be evaluating patients in their native or in preferred language. And if we don't speak that language, we need to use interpreters, translators as appropriate. And take into account the cultural impact of these injuries and how an individual's cultural background might affect how they relate to their injury and how family members relate to the injury, et cetera. So again, this takes a lot of introspection and flexibility from a neuropsychologist to appropriately appreciate and asking a lot of questions and seeking assistance from other providers with more experience. And then this last point in neuropsychological evaluation of these patients is critical because we know that age and education, or how many years of education an individual has obtained, uh, impact our cognitive functioning. So typically as we age and our cognitive functioning slowly gets worse, but this is really pretty imperceptible for many, many years. But then as we get into our 60s and 70s, this change due to age becomes more pronounced. And if an individual hasn't acquired brain injury at that time frame, we need to sort of suss out or investigate how might age also be impacting cognitive functioning as a result, in addition to the ABI. So as you can see, a lot of things, a lot of important considerations to neuropsychological assessment for these patients. And we do this so that we're providing optimal care and best measurement of individuals' cognitive and psychiatric function so that we can help them the most. Last point, neuropsychological evaluation and ABI research is a hot area, and it's one that is near and dear to my heart. Individuals with ABI are frequently maybe a part of a research study or maybe a part of some sort of clinical trial. And cognitive assessments or neuropsychological evals are frequently requested to be performed throughout a study at multiple time points, maybe at their baseline before they start a treatment, and then at multiple time points throughout a treatment to see how they improve from a cognitive or psychiatric perspective. So there's always seemingly work for a neuropsychologist to perform these types of evaluations throughout research. And then we're seeing a lot of improved integration of some of these measures of cognitive functioning that we give paper and pencil or person to person with neuroimaging technology, meaning we can better perform cognitive evaluations while an individual is having a brain scan or has an EEG net on or whatever. And this technology is always improving, and that's very exciting. And then in neuropsychological evaluation, we're always trying to develop measures of cognitive functioning that are increasingly sensitive and specific, and that more accurately relate to the outcomes of ABI. And this is a field of study that is always advancing. We're always trying to improve our ability to improve the way we measure cognitive functioning and psychiatric functioning in these patients. And it's very exciting because there's always new avenues to do this. In conclusion, I want to wrap up with the three broad points of this brief presentation. Again, an acquired brain injury is simply a brain injury that has occurred after birth, and it might include things like traumatic brain injury and stroke and all sorts of other consequences or mechanisms. Neuropsychological evaluations often play an integral role in acquired brain injury treatment and outcomes monitoring, as we've discussed. And then ABI research and neuropsychological evaluation go hand in hand in many cases, and allows for an appropriately trained neuropsychologist to have a role both in clinical and research endeavors, which keeps their career very fresh and very exciting. I thank you for your time, and I hope that this was a helpful primer to acquired brain injury and the neuropsychological evaluation of those patients. Thank you.